Good morning, everyone. Thank you for joining us here today at Lackawanna College in downtown Scranton, as well as virtually on Zoom for this important hearing to discuss the availability of healthcare in communities across our Commonwealth. I'm State Senator Katie Muth. I represent Senate District 44, and I'm the Senate Democratic Policy Committee Chair. And I'm honored to be sitting next to my counterpart in the House, Representative Bizzarro, who's the policy chair in the House Democratic Caucus. I just want to say also thank you to our co-hosting senators that requested this hearing, which is Senator Flynn, and then also Representative Kosierowski, and then members can introduce themselves who are also participating here in person, and I will announce members that are online as they're texted to me. Today's hearing will feature a discussion on healthcare deserts, a growing problem across our Commonwealth and really across the country. According to the Pennsylvania Health Access Network, there were 33 hospital closures in the past 20 years, including 15 in the past 5 years. The closure of emergency rooms, maternity care services, and hospitals in general are affecting communities across 67 counties in this Commonwealth, regardless of income level and regardless of whether you live in a rural, urban, or suburban area. I can say that Senate District 44, which is also Representative Dan Williams' territory in the House, who's here at the end of the table, we had a hospital closure in our area in Chester County, and it's the wealthiest county in the Commonwealth, and we still have hospitals closing. So certainly an issue that we're all here to talk about and very concerned about. I'll turn it over to Representative Bizzarro for his opening remarks.
Thank you, Senator Muth, and just to echo what Senator Muth said, Representative Kosierowski, Senator Flynn, thank you for having us in NEPA for this very important hearing. This is not an issue that is unique to just Lackawanna County. We're seeing this happen across the Commonwealth. It's really important that we talk about these issues and hammer out some important policy points after we're done with this hearing. So I thank you again for hosting this hearing and for having the committee back up here. And I'm going to turn it over to the members to introduce themselves, starting to my far left.
Good morning. My name is Dan Williams. I represent the 74th District in Chester County. I'm excited to be here to hear more about what I think is a critical concern of mine in the 74th, as well as throughout the Commonwealth.
Hi, Representative Kyle Donahue. I represent the 113th District in Scranton and North Pocono area. The two hospitals that are currently in the city of Scranton are both within my district, right up the street. I know this is a major issue. It doesn't just affect people in my district, but across the whole region and across the whole state, so I'm happy to be here today. Thank you.
State Senator Marty Flynn, 22nd Senate District, Lackawanna and Luzerne counties.
Senator Bridget Kosierowski. I also represent part of the city of Scranton, and today we're here to certainly speak about and have input about what we already know. There's lots of deficiencies in the Commonwealth with access to care, and today's hearing is to highlight what the solutions may be. So I'm looking forward to today's information.
Good morning, State Representative Jessica Benham from the 36th District, all the way over in Allegheny County, where we have a significant number of hospitals, but certainly face concerns from folks in the outer edges of the county and in the greater Pittsburgh region as a whole around access to health care. So looking forward to hearing more today.
We'll go to Senator Flynn and Representative. Oh, I didn't see you come in, Kyle. My apologies. Didn't see you come in.
It's the quiet ones you have to worry about. All right. I'm Kyle Mullins. I'm a state representative from the 112th District that runs from the borough of Dunmore up through the mid-valley of Lackawanna County, the Upper Valley, and the Carbondale area. Thank you so much for being here and being present to a very important conversation. And I'll turn it over to Representative Leanne Kruger.
I am Representative Leanne Kruger, just drove up from Delaware County. Crozier Chester Hospital, owned by Prospect, is in my district.
Now we're going to hand it over to Senator Flynn and Representative Kosierowski for some opening remarks. Start with Senator Flynn.
I would like to first thank Policy Committee Chairs Muth and Bizzarro for offering to hold this joint policy hearing on healthcare deserts. Healthcare deserts represent significant disparities in access to essential healthcare services, often affecting both rural and urban communities alike. Areas that lack adequate healthcare facilities and providers results in poor health outcomes, exacerbating healthcare inequalities. During the COVID-19 pandemic, we witnessed firsthand the importance of reliable and quality access to healthcare and healthcare facilities. Here are some facts why this is such a critical issue that must be resolved. In the United States alone, over 80 million people live in areas designated as primary care health professional shortage areas. Residents of healthcare deserts face 30% higher rates of preventable hospitalizations compared to those in areas with better access. Roughly 20% of Americans live in rural areas where they often encounter challenges such as limited transportation options and long distances to healthcare facilities. The issue isn't limited to physical healthcare either. Nearly 60% of U.S. counties have no practicing psychiatrists, psychologists, or social workers, exacerbating mental health disparities. As we continue to see fewer providers and a shrinking number of available facilities, it is incumbent upon us as legislators to find solutions to this growing problem. Closing the gap in healthcare deserts is crucial for promoting health equity and ensuring that all individuals have the opportunity to lead healthy lives regardless of who they are and where they live. And thank you again to our policy chairs. I'm looking forward to the testimony that will be offered today.
Good morning, and thank you again to Senator Katie Muth and to my colleague, Representative Ryan Bizzarro, the committee chairs for the policy hearings. And today's hearing is essentially about what we've just spoken about before with Senator Flynn and the statistics that he spoke about. Now, I'm a registered nurse, and I've been a registered nurse for 30 years, and I am laser focused on preventative care. It is the most important access for people to have preventative care, which comes from hospital access, doctor's access, insurance. It is the main reason that people can actually go on and live healthy lives with preventative care, being able to diagnose and treat treatable diagnoses before they get too far. And as a nurse, I saw too many people come to our operating rooms with advanced stage of disease because they did not have access to care earlier, access to preventative care. We have to fix this. We deserve better here in a Commonwealth. And I know that there are lots of people also trying to do the right thing. And we have lots of challenges, whether it be workforce, whether it be financial, whether it be access, whether it be transportation. We have lots of challenges here, but we can get to the solutions. So today I'm really looking forward to this testimony, answering questions, and like I said, getting to the end, to the solution so that our constituents have access to quality health care, which is really a basic need. So thank you very much for being here today.
Thank you all very much. I just want to mention that Senator Carney is joining us virtually on Zoom. So for those who can't see the Zoom screen, he is participating as well. So thank you, Senator Carney. And I'll announce other members as they jump on throughout the hearing. Our format for this hearing is we're going to give, we have two testifiers today. I anticipate a pretty robust discussion since there's a lot of members participating, which is great. So 5 to 7 minutes for each of you to do your verbal testimony. We all have the resources you sent in advance. All of that should be uploaded both on Rep. Bizzarro's and as well as my website at senatormuth.com/policy. So we share all of that written information. This is being recorded and live streamed. For those who couldn't participate live, the recording will be online afterwards to share out with your friends and family and make more awareness about this important issue. So I will start and I will introduce Tammy Torres, who's the president of the Lehigh Valley Hospital, Hazleton. Thank you so much for joining today, and the floor is all yours.
Good morning, Chair Muth, and also, good morning, Chairs Muth and Bizzarro, and representatives and distinguished members of the committee. Thank you for having Lehigh Valley here today to testify on our shared goals to increase access to health care in communities throughout the Commonwealth. Like mentioned, my name is Dr. Tammy Torres, and I am also a registered nurse. So Representative what you had to say really resonated with me, and you'll hear that throughout my testimony here today. In my role as a president for Hazleton, I oversee all of the operations in that facility. I work with all disciplines, all forward-facing departments. I work within the constraints of the organization, the network, which are 14 hospitals. I work within the Northwest region that incorporates Pottsville Hospital, which is Schuylkill County, and also the hospital at Carbon. So we all work as a set, as we roll out things for our organizations, but also within the constraints of the network as well. So we are 14 campuses throughout the region. We also have 21 express cares, urgent cares. We have 2 of which of those express cares are children's express cares. So that's very important to have that. We also have specialties: cancer, cardiac, neuroscience, orthopedics, and surgery. So we have that, whether in person or through telehealth or telemedicine. So when we're assessing the community's access to healthcare, it's important for us to not look at specific types of providers and services, but the strength of the entire healthcare continuum. And then what you'll see is, because when there's a hospital that either closes or does something with a service line, it really puts a strain on the other hospitals in that area to try to provide services. So let's just talk about behavioral health, because that's out there. We've seen the increase. Senator Flynn, you talked about the numbers that exist post-COVID. And so when these patients don't have access to primary care or early intervention services for these behavioral health patients, their systems, they do escalate into crisis. And so throughout the Commonwealth, you're going to see that strain that is happening in our emergency room in particular, because before we can send them anywhere, they must be cleared, medically cleared, to try to find a facility to place them in. So what we see is reimbursement for behavioral health services. They are long lagged. I mean, you've brought it up already. Those compared to physical health payments, they're just nowhere in sight. And so what happens when you do have and are able to recruit psychiatrists or mental health workers, they usually like to go into the private sector, because there's nothing to lure them into taking insurances, which are Medicaid mostly. And so there you see that gap already. So we've got to do something with these payments, because it makes it very hard for us to recruit when we do have that luxury. And through LVHN, we are able to recruit, but we do see them leave within a span of several years, leave our system. So, and these patients, they're coming in, these behavioral health patients, they're very complex. They have a lot of comorbidities that have not been addressed. And so when they land in our ERs, they could be here for weeks or months. And if they have a disability like IDD, then what you have is you can have them in your facility for a whole year before you can get them placed because of the payment. And we can't discharge them. We must keep them. We must keep them safe while they're with us. Meanwhile, they're being seen by our primary care physicians, those that staff the emergency room. And so just picture this. You're in an emergency room, and we've got a couple of psych patients, behavioral health, sitting there. They start to escalate. Our docs are trying to get someone from telehealth to really help us. How do we start to manage this patient? In the meanwhile, this person has escalated and is attacking, personnel in the hospital. I just recently had that over at my facility. He nearly strangled our patient, our provider, the person that was sitting, he wrapped a towel around his neck and was pulling him across the floor. Now you have people very ill there, and so they're watching all this as I have 3 doctors and nurses trying to get this person from being strangulated. Our sitter was left unconscious, had to go on disability as a result of this. Now we had him in his private suite, you know, making sure that we were handling, but has the escalation and we couldn't get to him fast enough. This is an outcome. So picture you, your family, and a loved one just being in that emergency room as this is happening. Now I've just inflicted trauma on you as a result of that. And so if we then admit them because we can't get them into a facility because of the payments, we then admit them to one of our floors. Same situation. You're trying to get health care, physical, diabetes, high blood pressure, whatever it is that we're trying to control for you. And then you have a person that is very mentally ill screaming on that same floor. No matter what separation, it is heard throughout the floor. So please consider doing something about our payments. They can no longer continue to lag because this will continue to happen, and we have difficulty placing them for the same reasons that you stated, Senator, that they've closed them because of the payments. You know, they've closed these institutions that we can send, these facilities that we can send these individuals to. So we have to look, because when we say we're not going to take this patient, somebody's got to take this patient. Again, I've worked at many facilities in the tri-state area, and so I feel fortunate to be at LVHN because I have resources. The green light is on? Can you hear me now? Okay.
We want people to hear you.
Okay.
Keep going.
Okay. So if we can do something about those payments so they don't lag behind, I think that's going to be the biggest and strongest solution to making sure that we have the facilities that we need for our behavioral health patients. Next, and I believe either one of the representatives, senators mentioned, when maternal health. Another very big one. We're very challenged in maternal health. More than 12% of Pennsylvania women and 47% of women in rural counties live more than 30 minutes from birthing hospitals. We see on an average over 180 babies a year being born in Pennsylvania EMS, teams that are en route to the hospital. We also see that when there is a hospital that closes its service because of the expense that goes into caring for mom and baby, that someone's got to pick up that lag. And so sometimes, because the nearest facility, transportation center you also mentioned, they will take local transportation when they can get, or a family member, or even an ambulance, and so they deliver in our emergency room. Again, another area that they should not be delivering in. So, we know, and as well as you're aware, that that increased Medicaid supplemental payments for OB and NICU that can help some of the units from closing, that hasn't been increased in over a decade. So most recently, we had one of our local hospitals close their doors to OB because of the expense. So yes, we have to deliver, and everybody wants the healthy baby, but when we don't have it, you need your NICU, you need your OBs, you need your anesthesia, you need your staff to be trained and to be competent. And so that is a big strain. So most recently, one of our closest facilities that delivers babies did close, and so now my facility has to pick up the bulk of that. And we're happy to do that, and we've had to add to the expense to have all these services. When you have the healthy baby, perfect, but when you have a neonate that comes out with trouble, you need neonatologists to handle this. So we've had to introduce things like telemedicine to help our pediatricians manage these babies until I can get them to a safer zone or a higher level of care, which is in Cedar Crest Hospital, which is in Allentown. If I'm flying, I can get them there in 15, 20 minutes. If I'm going ground because of weather issues, I've got 45 minutes to get them to my closest tertiary hospital that has that NICU, because we don't have one. So again, it goes back to that reimbursement. Now, if we have the baby that's born that is a NAERS baby, which is a neonate that has abstinence syndrome, which is a baby that comes out with withdrawal, that's even more of a bigger issue. In LVHN, we've had over 200 this year, so far, that we've had to, address. And so that's even more critical, because that baby, he needs specialized care to get them to where we need. Again, we get immediately on the phone with our neonatologists to assist, to help us. Just to make our hospital bring it to a higher level because of disclosure, I had to add $2.5 million to the bottom line to make sure that I had everyone in-house 24/7, even though you would consider my facility a low-volume hospital at only 650 to 692 births a year. But that's the level. So, but this is what we have to do for our community. In order to have our mothers and babies to be safe. So again, that, we've got to look at doing something with the supplemental payment and increasing that. It's been way too long, over a decade. And then lastly, just wanted to speak to you about the challenge with the healthcare force, and I believe you brought that up, Representative. And so, which came first, right? The chicken or the egg? Because what's happening with our healthcare force is that it's dwindling, and we do a lot at LVHN, which I'll get into. But we're projected right now, at least what I'm looking at the data, that in the next 6 years, the Commonwealth will need about 1,000 primary care physicians. When it looks at the shortfall of registered nurses, we're looking at over 20,000, shortfall. And when I look at mental health professionals, 6,000, and some support staff, which is the biggest thing. It's about 280,000 individuals that we'll need within the next several years to combat the shortfall that we're having. And, this really affects, our recruitment. So again, being part of a network, we have people that specialize in that, and we do put all the bonuses, and we look at salaries even in the most remote areas to be competitive. But especially with the newer docs coming out, we do something around tuition reimbursement for them. So I think that would be a possible solution as you look at all of the healthcare force, some tuition reimbursement for them to get them engaged, to keep them in our areas. When I interview doctors, it's about staying power. Please, what is the intent? Because we invest this time, we want you to stay with us. What else can we do? So we really try to give them a wonderful package so they stay with us. If you're used to the city, coming into rural or is not where you want to be. So we try to make it as much as a smooth transition as we can for our physician and all healthcare workers. Right now, we have a School of Nursing in Pottsville, and we've, for this upcoming year, have increased registration to get nurses to come through from 20 to try to at least get 100 to try to help us with this shortfall that we're seeing with our RNs. We're out there recruiting internationally, and also nurses, which is a new one for me to recruit from Puerto Rico. My parents are from Puerto Rico. It is the Commonwealth or territory of the United States, so it's easier to recruit there. So I'm heavily engaged in the politics of Puerto Rico to make that happen. One of the things that I hear from the professors out there, so we're all bilingual, and if and all the universities are bilingual or English only in the way they train their nurses. However, when I try to transition them to come over because family members have already come here, they're having some difficulty because they have to take the TOEFL, which is the testing for English as a foreign language for nurses that are Spanish speaking. So I can't even get them to licensure. We can't get them to take their nursing licensure, the NCLEX, because they have to take this testing. And so it's interesting to me that New York, Virginia, and other states, I think there's a total of 9, don't require this for those that come from non-Spanish, non-English speaking areas. So we should really look at that for the Commonwealth and see if there's anything we can do, because these nurses come. They, I can bring them here, but they still have to take this test. Then they have to take their registered nurse testing. So I think something has to be looked at, because we're up there with New York and New Jersey, and the Commonwealth is, in high population of bilingual and Hispanics in our areas. So something really to be looked at to help with that transition and getting them into these vacant positions. So despite all our efforts, you see that statewide our average vacancy rate remains in the double digits. So we'll need additional public policies and investments to build up this workforce. Hospitals and other providers face significant challenges to our long-term sustainability as the cost of providing care outpaces the payments. And we've just spoken, and you've recognized that as well, so I'm not going to belabor that point. But, even when we're working with the commercial payers, they really trigger off of Medicaid and Medicaid and how they pay 84 and 81 cents on a dollar for the delivery of care to Pennsylvanians, to Pennsylvania hospitals. And that's a significant shortfall, which challenges all the hospitals. It puts a burden on the greatest on the urban safety net and the rural hospitals. So we're seeing a lot of that. And just, as you know about reimbursement and what's happening, and this model is not sustainable. But I am sure that you've seen what recently happened with Walmart and their announcement of closing all their virtual, care services and healthcare centers, because after 5 years, they say that, they can no longer deliver this type of care just because of the cost involved. So I just wanted to leave you with that thought, and I just want to thank you for the opportunity to participate in today's hearing. Thank you.
Thank you very much. I was taking notes as you were talking, so I'm sure people will have questions. It was very thorough and helpful to understand all the efforts that you're putting forth to try to stabilize the system, not just now, but in the future, for sure. We'll go to Patrick Keenan, who's the Director of Policy and Partnerships from the Pennsylvania Health Access Network, and then after your testimony, we'll open it up to Q&A for all the members. Go ahead, Patrick. The floor is all yours.
Good morning, and thank you again for hosting this hearing. I just want to say, in listening to Dr. Torres, it's incredible where you can have a panel where, the next person says, we absolutely agree with the things, and there's more that we need to do. There's going to be no one-size-fits-all solution here, and I think that the moment for kind of looking at one part of the system versus another is over. We now need to look at comprehensive and holistic sets of policies, often which not everyone is going to agree on, but if we put the patient at the center, ultimately we'll get to a solution that will meet the patient's needs. You all may know some things about the Pennsylvania Health Access Network, but we spend a lot of time talking to people all across Pennsylvania. Every year we talk to about 10,000 Pennsylvanians about their different healthcare needs, whether it's accessing coverage, resolving a medical bill, getting help finding care because it's not available in their local community. We have people in rural, urban, and communities in between. So we spend a lot of time kind of learning from their experiences, and that's how we initially got into this issue of healthcare deserts. When we talked to individuals after the closure of Brandywine Hospital, you know, one of the patients that we talked to summarized it in the best way, better than any policy wonk ever has. You know, he talked about, you know, that closure meaning, you know, it's not that there is no care in Chester County. It's about leaving your home community where all of your records are, having to travel now to Westchester, seeing more people traveling to a place that's not designed to accommodate that extra patient volume, ultimately having to wait longer for doctors, and ultimately seeing his friends and family give up on getting care altogether. He summarized it like this. He said it has snowballed into a kind of healthcare hell. And so I think that just, you know, that's what we're really trying to work on when we talk about addressing this issue. There's so much that we don't know in why hospitals are closing, but fans started to dig into this issue. And one of the things that we realized is that a merger, acquisition, or change in ownership is one of the best predictors that community will experience a full or partial closure. Often people want to kind of tackle the issue of healthcare closures at that moment of closure, but it's too late. What we're trying to say is now the moment to start looking at closures is when that merger, acquisition, or change in ownership happens. And we need more transparency. We need a public interest review process around those mergers, acquisitions, and changes in ownership that empowers local officials to learn about what's happening, to plan, to strategize, and also ultimately get commitments from the entities that are looking to merge on the record so that, you know, we can preserve that access to care and avoid that kind of snowballing into a healthcare hell. That's certainly not anything that we want. I also think that when we talk, you know, I think about this a lot because, you know, my family's from northwestern Pennsylvania, and I think about, you know, what it means when we've heard about the closures of maternity wards. When we talk to a lot of family and friends and other people in the communities, often those that are of childbearing age that are considering starting a family are really starting to consider whether or not they can be in the communities that they've grown up in because they're nervous and honestly terrified about what it means to kind of travel. I look at, you know, my family's from McKean County. When the maternity ward in Bradford closed, you know, everyone's like, Olean's close. But, you know, when you think about the winter, when you think about driving up those roads, when you think about those critical moments when someone goes into labor, what does that mean? You know, we heard about the number of babies being born via EMS or, you know, not having those local services. So it really does change not just the, you know, not the availability of care ultimately changes the whole trajectory of what our Pennsylvania families are kind of thinking about. We used to think a lot about this as just a Pittsburgh thing. You know, we used to think that, you know, this was something that Western Pennsylvania, you know, had to deal with as hospitals merged and consolidated and the landscape changed. And I think that we've all realized with the kinds of closures that we've seen recently that, you know, this isn't just a Western Pennsylvania thing, that this is something that we have to deal with the whole state. And so I think that beyond the public interest review process, we need to look holistically about why mergers, acquisitions, and change in ownership are happening, often what we see is we see that larger hospitals want to get bigger, often so that they can charge more and more for the care that they're providing. The business model of healthcare has changed, and maybe it's because of the reimbursement, that could certainly be a part of it. Maybe it's because of the workforce, but we really have to look at some of the system-wide dynamics when we see really wide price variation. And in the testimony that I provided to you all, you can see prices vary wildly, even between, two merged systems. So often it's the race to get to the biggest, the fastest. And when our families are dealing with high deductible health plans, when they're dealing with coverage and they need to look at paying a deductible first before getting their care, often these bills can range in thousands or tens of thousands of dollars. And it's a problem that we really need to have more oversight. We need to incentivize competition and choice in the healthcare landscape. I also think one of the things that we heard from patients, when we talked to them about healthcare deserts, because we brought this topic up and said, what does this mean to you? And it evokes, when you think about a desert, a dry and barren place where there's no healthcare that's available. And patients said, well, that's not really my lived experience. Any kind of care that I need, if I need care for my diabetes or if I need some kind of specialized care and that's not available, that's a desert to me. Even though my neighbors may be able to kind of get the kinds of care that they need, if I can't get the care that they need, then I'm in a desert. So this is why we really need these kinds of solutions that look holistically at the system. Now we've listed, we talked about, we also blend not only the anecdotal piece, but also the data piece. And Senator Muth, cited some of this in her opening remarks. When I said, we used to think about this, we would talk to folks in Western Pennsylvania, representatives and senators would nod, and some of their colleagues in the eastern half of the state would not. So I think it's really important to know that this is being held here in the eastern half of Pennsylvania. I think it speaks to that trend that's happened just in the past 10 years. But 1 in 8 Pennsylvanians have said in the last year alone they've been impacted by a merger, acquisition, or change in ownership. The most commonly cited example is that they've lost access to the doctors that they have relied on, often for a lifetime, to administer the care that they need, the doctors that treat them and know, because often in this reshuffling of the deck, patients end up on one side or the other. So we really need a solution. A desert in this instance can often mean the care is available in your community, but you can't access it because of the card that's in your wallet. So we really have to think about solutions not only that are going to address payments and workforce, which are so critical that Dr. Torres talked about, but we need to talk about the broader business dynamics. We need to talk about the motive that larger hospital corporations and systems have in these, and we need to look at solutions that are supported in a very bipartisan basis. So when we got that 1 in 8 stat, and we talked to people about how they were skipping or delaying care altogether, we also presented solutions to them. And you can see these are listed out in the testimony that I provided, but there's really strong congruence. Republicans, Democrats, independents, all supporting these solutions. I don't think that this is a regional thing anymore. I don't think that this is one thing that belongs to a particular party. It's really something that we see strong support for among voters and constituents from across the Commonwealth. So we asked about anti-competitive practices and limiting anti-competitive practices. Recently, the House dealt with the prohibition, the prohibition from working for a competitive health system. We hope that the Senate takes that up. But there are other anti-competitive practices in the industry that we need to deal with. We also need the government to look at driving more competition in healthcare markets and improving choice. Ultimately, when it comes down to that, if we don't preserve competition and choice, or if a closure means that you only have one place that's not real choice, for patients to choose from, and that's why we need to get ahead of this before it even happens with the public interest review process. And then ultimately in the House, a hearing has been held in the Health Committee about, with the Attorney General's office. I would encourage you all to look at what the Attorney General is asking for, specifically more in the antitrust space. Often, the thing that was most surprising to me is that the Attorney General's office is often looking to the newspaper and to other sources for information about transactions before they even happen. So those are the kinds of things that we can tackle in a very practical, pragmatic way right here to make sure that no Pennsylvania patient is living in a healthcare desert. And with that, I want to thank you all for the time that you've spent with us today.
Representative Kosierowski and I are sitting here commiserating about health insurance coverage and just the struggles as she's witnessed personally and also in her job, and same with me as a former athletic trainer trying to fight Medicaid for out-of-state student athletes. It was cheaper to fly them home to their home state to get an MRI than to pay out of pocket. So my husband and I used to negotiate knee braces out of pocket with Dawn Joy, trying to get people covered for what they need. So thank you both very much. I'll start the Q&A portion off. You can start it off, Representative Kosierowski.
All right, thank you. I was like intently listening to both of you, shaking my head, agreeing with everything that you're saying. And Dr. Torres, when you talk about the 20,000 shortage of registered nurses and the bonuses that they're offering, I said yesterday, if this gig doesn't work out for me, I'm going to put my scrubs on and go back to work because you with me, yeah. So we'd have to I'd probably have to go back to nursing school though. And that NCLEX word sends me into full-blown tachycardia because those were our boards. So yes, I was over here and enjoying your testimony very much. But we talked about the solutions, and Patrick, you spoke about like patient focused solutions. There's lots of solutions that we can work on here: funding, access, transportation, telemedicine, workforce, but the continuity of care. When you spoke about the hospitals changing. Some doctors don't have privileges anymore in the hospital. They're being seen by hospitalists. We live in a commonwealth that has an incredibly high rate of geriatric patients that are everything from hard of hearing. They don't have family here any longer. And when they go to a hospital after being taken care of by Dr. Smith for 30 years, and now you've got a new physician in-house taking care of you and you're admitted, it causes an incredible amount of anxiety. Sometimes there's a lack of communication, and those lead to sometimes mistakes that are made, or patients aren't having the best communication with their healthcare providers. I spoke to a family doctor recently that is acting at this point as an oncologist, a radiologist. He was, trying to get schedule a patient had a colonoscopy that showed a cancerous mass, needed to see a surgeon, but to get these patients to see, you can't pick up the phone anymore like the old in-call, and say, can we see Mary because she's coming in, and that kind of care and continuity in hometown, care, especially here where I live in Scranton, and I remember the way that was done, makes me sad. But I think we can fix this, and I think we are on the verge. Like the Commonwealth has many hospital systems that are closing, whether it be because of profit or because they've turfed things out. We all know that there are certain specialties in hospitals that make money, and those have all gone to outpatient services. And you hate to say it, but we don't make money taking care of our sick patients anymore, and that's where we have to fix the issues. And you talked about reimbursement. But with recruitment and retention and bringing people to come and stay and work in our hospital systems, I think the question for Dr. Torres that I have for you is, what do you see the biggest challenge in retaining nurses at the bedside? That's where I think we have our biggest void of keeping our nurses in the hospitals to work at the bedside, whether it be ratio, whether it be pay. I don't know what you think the best solution to combat that problem, because when you don't have nurses to take care of the patients and the beds are not able to be staffed, then it's a trickle effect. You've got patients in the OR that can't get to the PACU because the PACU can't send the patient to the floor can't discharge the patient to long-term care. It's a big, huge problem, but I think it's the workforce that we have to really pay attention to and lift up.
Representative, I couldn't agree with you more. And so you've already identified what the issue is and why it's happening.
Now tell me how to fix it.
Yeah, right. So I can just speak to what we do at LVHN. But before I get to that, what you said, Patrick, resonated with me because I was at Brandywine. I was working there, and when the announcement came, right before the announcement came that we were going to close that facility, it's a for-profit, obviously, and so I had been asked to take on the role at another facility that I actually ended up transitioning to a hospital system because it was a standalone, and we were going to have a healthcare desert if that wasn't done. So I just needed to say you brought back a lot of angst and memories when you brought up Brandywine. So to your question, what we try to do for our nurses is really keep them competitive in their pay. We work within the ratios, and we try not to extend those ratios unless we absolutely have to. So let's say on a med-surg floor, we usually work 1 to 5. So I try not to go beyond that. But sometimes we have to, especially if you're holding so many patients in an emergency room, because they've got to go somewhere. The care has to come. So we look at bonusing them, rewarding them for the work any time we get. We really look at working as a team. So there's no task for any of us that we won't do if there's something going on the floors. Now, you know, I'm not against, because I do still have an active RN license to go and be a set of helping hands, but will not get into the patient care. And I think you'll see that throughout our hospital system, that is the way we work. I think putting things in place to help us, like I said, especially with the nurses from Puerto Rico, would help us, you know, infuse all of our hospitals, Allentown, Pocono, all of our hospitals with new nurses. And then because we're all in highly populated Hispanic areas, so then that helps with the language, you know, being able to speak to our patients. But I think it's trying to do the right thing always for not just our nurses, but for a whole entire workforce when no one is looking.
Thank you very much. And Senator Muth and I were also, we will definitely look into the language test, the foreign language test. We were in our copious notes we're taking, that's on our agenda. So thank you very much, Doctor.
Really, she's just being kind, and she's like, of course Pennsylvania is one of these states.
I
That's
did, I
just
said
so
that.
we were both like, no shock here. Like, God forbid
did
we
say
do
that.
anything, you know.
Thank you.
I'm going to go through the list so everyone knows the order. Representative Williams, Representative Kruger, and then Representative Bizzarro. So far, line up for questions. Go ahead, Representative Williams.
Chair Muth, thank you. I want to thank you both, Dr. Keene and Dr. Torres, for your testimony. It's been helpful, and I wish I could share the positive outlook of my esteemed colleague, Representative Kosierowski, but I just don't. The Brandywine Hospital, as well as the old Coatesville Hospital, located on Stewart Avenue, I've been there for about 30 years observing this movement. My wife is a nurse who's worked in both of those facilities for decades. And so part of my tension is we continue to approach something that I think by your own testimony, because of reimbursement, because of payoff shortfalls, we're looking at something that simply is not sustainable. And to continue to do what we've always done doesn't appear to me to be effective. When we're looking at this model of healthcare delivery, and we keep attaching it to the word business, it appears to me that as a business, systemically, we're headed in the wrong direction. Some of the closures that we are talking about, when you consider 33 closures, we're talking about business models that are running the healthcare system, and we haven't yet mentioned the word greed. So the idea to continue to do what we've always done seems to me somewhat pointless. Because unless we do an overhaul of the system, change the paradigm, we'll be back at these tables for decades. Now, my question to you is, is there a connection between the quality of care and hospital efficiency and closures? And the reason I raise that is because back in the 70s, there was something called DRGs. They were diagnostic-related groups. And you began to see the handwriting on the wall with the decline in some services and some spaces that sort of have brought us to this place today, DRGs. And so I'm curious to know from your perspective, is there any correlation between these closures and what ultimately begins as a decline in efficiency in services for some of the closures we're seeing today?
Representative Williams, I really appreciate the point that you bring up, because I think that that change of paradigm is critical, and you're kind of speaking to something that we may not have highlighted as clearly in our testimony, but it's absolutely correct. I think that number one, you talk about a business model for healthcare, and last time I looked, none of us can choose. If you're a consumer on Amazon, you have a whole list of things that you can kind of pick on, and you look at the reviews and you look at the price, and ultimately you add something into your cart and you buy that, and it arrives 2 days later at your house. Healthcare doesn't work that way. You can't choose, oh, I'm going to have a heart attack today because that's the most profitable thing for the hospital down the street. Or I'm going to develop this kind of condition, this kind of cancer, because the reimbursement rate is the highest for that, right? So we can't look, patients certainly don't look at healthcare as a business. Now, I realize that you need to have a basic level of income to be able to keep the doors and the lights open, to pay the professionals that are by the bedside. All of that needs to be handled. But when you look at the status of hospitals in Pennsylvania, the overwhelming majority of hospitals are nonprofits. So we really need to keep that in mind. And they're nonprofits maybe within large systems. So while one small entity may not be profitable, when you look at the whole systems, these large systems that are responsible for these smaller entities, there's record level tax breaks that are given to these nonprofit entities that have a huge amount of profit in them. And so I really think that we need to look holistically at that, right? Because we apply the logic of business, but it just simply doesn't make sense. And to be very clear, we need to start digging deeply. This is why no one size is going to fit all. If we do the reimbursements, we need to start looking under the hood, because we hear a lot about hospitals saying it's just not profitable to maintain this. Well, is that true within the context of the entire health system? How is it that when Tower acquired Brandywine Hospital, they were already looking to sell Brandywine Hospital before the ink was even dry on that deal, right? I think that we really need to start looking underneath that and saying, because ultimately what it means is to each of your counties, those nonprofit entities are, we talked to a patient where there was the opposite of a desert, right? He said, I have 6 hospitals within 25 to 30 minutes. And I think that that's something that Rep. Benham also kind of talked about in the Pittsburgh area, certainly no shortage, right? So we need to kind of start looking under the hood and saying, maybe it means with any kind of business, if Brandywine, isn't making it, but the overall system is very healthy, right? We need to start doing that holistic analysis and stop looking at it purely in terms of, is this one, it's not an Amazon, is this one product profitable, right? Like, I think that we need to look at overall the money that's out there and the tax breaks and the whole picture of finances. So I really appreciate you kind of calling into question the whole system that we may not even be talking about it in the right way. Thank you.
I appreciate your response. What I'm going to do is, Chair, I'm going to yield because right now my mind is on fire. And I have 1,000 questions related to CEO pay that I won't move into at this moment. I'll simply yield. Thank you for your testimony, Chair.
I share your rage. Representative Kruger.
Thank you so much, and thank you both of you for testifying today. I made the trip up from Delaware County because we're dealing with a urgent healthcare desert issue. Back in 2016, Prostac acquired the Crozier Health System, which had been a nonprofit. We've seen now the closure of Delaware County Memorial Hospital and Springfield Hospital, and are fighting very hard to preserve Crozier Chester Hospital and Taylor Hospital, which are owned by the same system. So we are at that key point, Patrick, of a merger, acquisition, or change in ownership because Prospect has put the system up for sale, and the Attorney General's office is providing oversight to the process because of pending litigation. So I'm curious for both of you, what's your perspective on the role of private equity in healthcare, and not just in acquiring entire systems, but I've heard from doctors on the ground that the specialty practices are also being bought up by private equity at this point.
When you look at the, first of all, I want to point out that, in our testimony today, we talk about, that proximity, when Delaware County and Springfield closed. I think it's your colleague Rep. O'Mara that said it best. It wasn't that there weren't any hospitals in Delaware County, but have you tried at 3 o'clock to get anywhere in Delaware County quickly? And if you have an emergency situation, right, those local community hospitals really do make a difference. When you look at the distance between Delaware County and Taylor, it's not insurmountable on a map, but if you are a resident that was proximate to Delaware County Memorial and have to rely on SEPTA to get there, it's going to take you over an hour and a half. So if you're talking about, an individual that needs to be seen routinely by a doctor, now you're talking about like days out of your calendar, right, that need to be taken to do that. So one is, the private equity has come in and record, we can look at Hahnemann. We can look at, what's gone in Crozier Chester. There's plenty of examples here, and that's why we go back to this public interest review process. If we had started before Prospect had acquired, and we had really, taken the moment to kind of look at that, we might have better information. And again, the Attorney General is asking for specific authorities and permissions. Pennsylvania lacks an antitrust statute. For all kinds of things, so not just the healthcare space, right? But we are one of the few states that doesn't have that. But in the healthcare space in particular, if we wanted to drill down and be very focused in on that, there is specific authorities in the healthcare space that the Attorney General is asking us for that office doesn't have. So I think that that's one thing. I think that the public interest review process is another thing. Those are the things when we look, if we back up a little bit, at the federal level and also at the state level, we were all outraged about surprise medical bills where people do everything in their power to avoid getting a bill and then, show up at care that's in network and end up with an out-of-network bill at no fault of their own, right? And often surprise medical bills became a problem because private equity-backed doctors saw that as a profit-making strategy. They saw that buying up doctors' practices, buying up subsets, kind of looking at some of the hospitals that are really struggling and say, look, we can bring in a private equity-backed team of doctors to fill this staffing need because you don't have the staff. But ultimately what they want to do is extract that profit motive, and they're kind of relying or preying upon the fact that we really do have these significant workforce shortages, right? So private equity overall is becoming a very systemic part of our healthcare system, and we just need, I want to say stop it before it starts, but that's not true. There may be some instances where this is going to work. It doesn't mean that every transaction, every merger is bad. It means we're simply not looking at it before it happens to understand the impact on the community. So I would really encourage, in the private equity space, some people have talked about outright bans. I'm not certain that that's going to be the solution that we need, but we've got, the Attorney General, and we've got other processes that we can put in place to look at that before it starts.
And when you're in the midst of a process like we are, how do you provide accountability?
Well, I think that honestly, doing what I think that we need to do what you're all doing here, and we need to have patience. We need to have elected officials. We need to have everyone elevating the on-the-ground conditions for folks. I don't think that we necessarily have the tools that we need to be able to provide that in this instance. But I would defer to the lawyers and the folks that are really smart in kind of taking that on. But I think that we really need to elevate the patient experience. And use the bully pulpits that you all have, in your local communities to kind of highlight the problem and making sure that we keep it front and center, because patients are frankly terrified. And so I think that we need to, the more that we can have them speaking up and speaking out, the better off we're going to be.
Thank you.
I just had a follow-up question about the accountability piece. Are you working, I'm sure you're working with the local regulatory agencies to make sure that there is some accountability, that once, however this transitions, that hospital and others, that there's accountability, that they would reopen, has a network or a system. So are they looking at all that? Because that is, like Patrick is saying, that's the homework before you transition to something else. Because they're all needed.
Yes, no, we're in the midst of that right now. But this is a system where DOH and DEP have already provided accountability because of poor management practices.
Thank you.
And I asked Gareth to put in the Zoom chat, and I can send it to all the members. Private Equity Stakeholder Project has some good stuff on hospital and medical related buyouts. And I've learned to interact with them quite regularly because I sit on the PCERS board, and I don't want to bear a bad news, but maybe a policy idea is that we don't invest our state pension dollars or have some sort of stipulation for our dollars to be invested in some of the Bain Capital, Apollo, all of these big private equity firms that are the giants of buying out healthcare systems, that if we're making those investments, that they're responsible. And I can state, I'm not on the CSRS board for the state retirees, but for PCERS, there is no parameters around any investment in terms of like moral good, or I would argue fiscal responsibility means like people in Pennsylvania are being taken care of, because then you would have increased medical costs if they're not, right? So how we can think of some policy ideas around that as well. Go ahead, Representative Bizzarro.
Thank you, Senator Muth. So knowing that access, coverage, and staffing remain an obstacle to care, and understanding that there's no one fix to solve the entire problem, and we know that there are financial challenges that hospital systems across the Commonwealth are facing, particularly with the increased cost of care. How do you recommend addressing the sustainability of hospital operations? A quick answer if we can. I know that it's not a simple answer, but just to give folks who are tuned in, who might not understand the nuances of everything that we're talking about because it's so heavy policy related. But if you were to give recommendations to your average person on the street, what would you say that to them on how we can address this, the sustainability of hospital operations in order to keep these hospitals open in communities?
I would just look very simply to Massachusetts and what they've done with the Health Policy Commission. And, this is going to be the answer of a health policy wonk, but data can be our friend, because right now we have no objective, quantifiable, clear data. We have the representation from every party that has its own conflict, right? So the hospitals, you can use numbers to your advantage in any way that you want. And so what Massachusetts and other states are starting to look at is having one central repository that looks at the finances, looks at the cost of care, looks at the patient impact. I think for us, the thing that we're starting to see about their, how they track out-of-pocket expenses and is care affordable to folks, right? They start to centralize that data in one place. And unfortunately, in Pennsylvania, it's very broken up. You have hospital financial statements, you have the data from PHC4, the Healthcare Cost Containment Council. Like, there's no one place where you can get a clear picture. And so I would say, to provide the transparency is the best kind of accountability that we could bring to this, to have real, clear, objective data that not only talks about the hospital experience, but also the patient experience.
Yeah, I would have to say I agree. You know, there's so many hidden costs, or that's what, you know, our patients tell us when they come in through the door, you know, if there was more transparency. But like Patrick had said earlier, you know, what is the cost of a heart attack? But there's got to be a range, right? If you don't have to do interventions for that disease process, then is it a range that we look at? You know, I don't know if that has been looked at all in terms of the cost of what that hospitalization, instead of getting these bills. This is anesthesia, you know, this is your specialty bill for your cardiac surgeon, so it would be nice. Thank you.
Rep. Bizzarro, I just want to point out that Representative Khan and Representative Rowe introduced recently a co-sponsorship memo on hospital price transparency and facility fees. It's not the comprehensive solution that we're looking for, but Pennsylvania is in the bottom third. We're actually in the bottom 12 of states that comply with the federal regulations, and so we really need a legislative effort here in Pennsylvania to mandate simple compliance with what's already the rules at the federal level, but we could bring that to the state. And so that's the clearest example of bipartisanship working together of that hospital price transparency and facility fee bill. So I would also point that out as well.
Thank you.
Representative Benham.
Well, thank you. And thank you both for being here and for your important work. It truly matters. Patrick, you, of course, referenced that in Allegheny County and out west, one of the major problems that we're dealing with are some potential issues associated with mergers and acquisitions. And you aptly spoke about the impact that that can have on patient care. And I'm wondering if you, or you as well, can speak to the impact that that might have on staffing. Because I've certainly had folks talk about the potential challenges that a merger or acquisition can have when it comes to that transition for the staff.
I'll just talk very briefly because I'm the patient advocate, so I'll defer to the folks that are on the front lines every day. But what we've seen, you know, when you take Bedford and Altoona as kind of an example of where we've seen consolidation, the staffing at Altoona has become so untenable because of the same thing that I referenced with Brandywine and Representative Williams's district, right? The more volume that, you know, comes into those doors, patients talk about it as waiting for hours. They talk about seeing a doctor that spends 3 minutes with me, having a nurse kind of, you know, barely able to take my blood pressure because they have to run out of the room to do something else because there's another call button going off. So the patient experience is very much that when we, you know, close or consolidate or try to say like we're going to take services away and shift them. I think shift is the popular word, right? You know, shift them to these centers. It simply doesn't work because that's overtaxing, you know, already stressed resources. So, so often, you know, I can't speak to what it's like to be on the front lines, but from the patient perspective, it means wait times, not getting the care, not having someone listen to you, and ultimately giving up. Patients, when they have those kinds of experiences, it makes sense. Why are you going to do something that isn't working for you so you don't show up for that next appointment?
What I've seen in my career trend is when you have these acquisitions or mergers, it really doesn't touch the staff level. That's what I've seen. All those forward-facing units in, you know, wherever in a network, enterprise, whatever you want to call it, that's not where you see decrease in staff. You really see it at the higher ranks, you know, where you might have different divisions of people all sort of doing the same thing. That's where you see those layers being cut off. And that's where you see the cost savings of those dollars is at that level, not at the staffing level. That's what I've seen being in the field.
Oh, thank you, and I certainly appreciate both of your answers and, of course, understand the ways that this can really impact where and how patients receive care and whether or not they receive it at all. Very concerning. I think, you know, I have heard concerns, particularly from, you know, folks associated with either nurses or other bedside care beneath the level of, or next to the level of physicians. And so, it's interesting to me to hear that particular narrative around not seeing this impact the staffing level. And I wonder if maybe there's a regional difference there. Certainly out in Allegheny County, I hear quite a lot from folks, particularly nurses, who, as they work alongside physicians, are very concerned about whether or not there will be continuity of care and the potential impact as well on contracts or if there's a union contract negotiations.
Rep. Benham, I would just say, I come from a family of nurses. Both of my grandmothers were nurses. My aunts are nurses. And I just want to say, I think that it was a different model back then, right? Where you had, community-focused care, where you had small independents. So getting back to kind of that business model, I think that we really, if anything's going to happen, we need to make sure for those patients that we have to increase the staffing, not keep it the same. And, I just think it's really important to say, if you're going to see a change in the system, you need to put more staff in place, because I think that's the only way we can keep those nurses. It's not just about pay. It's also about what can you realistically handle in any given shift. And with that increase, we see more and more patients pushed to centers and places where care is happening. And so we're already stressed with staffing, but we need to add even more if we're going to do these kinds of things to make sure that those nurses can remain at the bedside.
Absolutely, and that, of course, is where our role comes to bear, understanding the stresses that are, at hand for hospitals as they try to meet staffing ratios, as they try to ensure that there are enough providers to adequately care for these patients. We understand that reimbursements pose a challenge, and that oftentimes these systems are doing the absolute best that they can. Though, of course, as we start to see more of the role of private equity, that becomes concerning there as well. But broadly speaking, we have a role as legislators to ensure that you are able to pay your staff a wage and provide benefits that retain them, whether you're going through a transition, an acquisition, a merger, or not.
And what I'm also seeing is, especially as it relates, Patrick, to the bedside nurse, is we look at everything that we can take away from that bedside nurse by having others do it, maybe virtually, to really keep them tied to what's going on with the patient, because sometimes it's all the paperwork that's required, it's all the monitoring, so having all that done virtually also gives a level of satisfaction and increases that visibility, so that patient that's receiving that care doesn't feel, oh my God, I'm not going to ask the nurse to do one more thing because she's run up and down, this unit all day long. So there's other ways that we're looking at it.
Representative Williams.
I apologize. This is the last time I'll speak. In terms of full transparency, do you think it would be helpful if there was legislation formed that enabled the Department of Health to review applications, require public hearings, impact statements for hospital systems before they were purchased?
That is what is happening now, at least, in the state where I was practicing when we were a for-profit, small, standalone hospital that converted and went into a system. They did hold public hearings and we filled an auditorium to make sure that there was not that healthcare desert by removing this hospital. And so it was acquired by a hospital system. So that is actually happening. I don't know if that happens in the Commonwealth, but I can tell you in other states, I've been a part of those hearings.
The federal process for reviewing healthcare mergers and acquisitions is often focused around what would be the equivalent of the Attorney General here in Pennsylvania. And so I think that, the Department of Health has a lot on its plate. So certainly they have a role as, the credentialing body. But I also think that we can't forget about the role, it's easiest to kind of replicate what's going on and make sure that systems align. So I think that we should be really looking at the Office of the Attorney General and again, kind of going back to whether it's antitrust behavior, whether it's specific health care, But ultimately what we've seen is we're talking often about national corporations, sometimes multinational. We have some nonprofits, that may have satellites in other countries, right? So I think that we need to think about this as making sure we have legal accountability, and that when all of these lights go off, and when the cameras are no longer kind of pointed in that direction, that everyone lives up to their promise. And so, the Department of Health may lack that kind of enforcement mechanism that the Attorney General's office has, which is really about if someone violates the promises that they make, that they can go after them in a legal way. And I think that that's probably the strongest and most appropriate way for us to direct our attention.
I appreciate that. Madam Chair, thank you.
Representative Flynn's gears are turning. I was waiting for him to ask a question. I guess I will add something to Representative Williams' question, and just in terms of the enforcement mechanisms in the Office of Attorney General. What I have found, even in the Brandywine process, but even in other parts of the Office of Attorney General that are in a specific division. For example, we just had a hearing last week on new home construction and just consumer protection nightmares, and the staffing even at the Office of Attorney General for some of these really specific but important initiatives that we're talking about, including this one, is also limited. So it's how much can 3 people dig into? I mean, I sit on a pension board and spend a lot of time reading SEC reports, and I was just saying to Rep. Kosierowski, the other piece of this that I think I knew, but maybe not in the context since we're having this hearing, is that nonprofit hospitals, or county or state-run, publicly owned, they can have private equity firms, their management company, running the hospital. So just because it's labeled, and I'm not saying, I have not, full disclosure, researched which ones in Pennsylvania, so I don't want to imply that that's a thing, but sitting here thinking about that is you call yourself a nonprofit, then how is it even, I mean, I'm not a lawyer, but legally, how does that even fit into your nonprofit, but you have a private equity company, which they're the giants, to be clear, the ones that are mentioned in the report I was just reading, is that they're the big dogs. So they're not, because it's, to your point, not all private equity is bad. Some things good have come out of private equity. There's just a lot, in my opinion, that are really terrible. But these bigger giants, these capital firms, again, I don't know that our Office of I don't know how that, it's kind of like David and Goliath, and that's sort of how the home construction hearing sort of panned out. We can do X, Y, and Z, but we may never, you know what I mean? Patients may never get reimbursed. The consumer and the taxpayer may never see, the award from those prosecutorial efforts. Does that make sense? In terms of should we just outright ban something, or say, if you are if you're going to have a private equity management firm run your we need to know that needs to be disclosed, because that's often buried in proprietary contracts. I read SEC reports and I go bananas, and sometimes that's not even helpful. I mean, I'm not even allowed to see an investment contract as someone who has to vote on this stuff. So I'm just saying, how do we prohibit that piece? Because it's very misleading to say, to your point, these nonprofit hospitals, some of which who are laying off workers as we speak in Western Pennsylvania, they get tax cuts, they're tax exempt, but yet you have a private equity, if that were to be the case, is that something we should have detailed guardrails around and required transparency at minimum, if not very tight rules around it?
And I want to be really clear, it's transparency with teeth. Because we have data doesn't do us a hill of beans. In other states, that I was referencing to Representative Bizzarro's question, what they do is they have enforcement mechanisms put in place. Our legal apparatus, our oversight and monitoring apparatus has not evolved significantly since the 80s. I mean, I'm not an expert in the budget of the Attorney General, the Department of Health, or any of these things, but they're certainly at the moment not equipped to kind of deal with the massive and monumental change. You know, when you, in your opening remarks, talked about 33 closures in the past 20 years, and more than half of them happening in just the past 5, right? Like that means that, you know, and our data shows that things are accelerating at such a very quick pace that we need to resource, you know, whether it's, you know, asking the Attorney General what kinds of resources they need to be good at enforcing it, putting in the things that they're coming to us and asking us to give them additional authority, and certainly it's up to the balance of powers to decide whether that's warranted, but we're all talking about a crisis, and the person that's on the front lines is saying, give me this, right, I need it. And I would imagine with that goes, you know, additional funding for staffing, additional funding for the outside contractors that you need to make these very complicated legal cases. And so, I mean, all of that, that's the holistic response that's going to put the patient at the center.
So, okay, here's my question. Looking at this from like a high point view, looking down, historically in Lackawanna County alone, you know, we had the Carbondale Hospital, Sacred Heart Hospital, we had the Mid-Valley Hospital, we had CMC, we had Mercy, we had Moses Taylor. So that's 5 hospital systems right in this county. Okay. Now all we have is CMC. CHS is going under, we all know, okay, and Lehigh Valley Network. So looking at this, no matter how efficient Lehigh Valley Network runs or how efficient Geisinger runs, the 230,000 people in this county aren't going to be able to be served properly. Right now there's a 4 or 5 hour wait in the emergency room at both places. If I'm a trial lawyer, all I have to do is go on TV and say, have you waited 6 hours or this? Come on and see us. Think about that though. Now when CHS closes, it's going to double the wait time in both places. So when people start dying, more people start dying, who is responsible? What are we going to do to actually fix this and find more locations for the population? Because our healthcare system is worse now than it was 50 years ago. Just by the due fact that people in the proximity issue, they can't get to them. Where doctors 50, 60 years ago could get to their patients, where now they can't even get to them because a person lives 40 minutes away on the other side of the county. So do you think we should transition more to like a Lehigh Valley network, like more Ready Center type care, or smaller hospitals in different parts of the county, or back to the old way with more centrally located? Do you think there's any angle there too?
I think that is the angle that we are using at Lehigh Valley, is really to look at those areas that they're seeing healthcare deserts in and put in what we call the neighborhood hospitals, 10 to 15 beds, to really access that community. Because as much as we want our patients to come to our locations, they can't get there. So we've got to go back to the old way of doing things, right? What's old is new again, and is having your local hospitals in those areas.
But a lot of times you just become a holding center for Geisinger then, because the specialists are there and they just...
Telemedicine, you know, we use a lot of telemedicine right now for all different, whether it's urology, neurology, to at least have the patient seen. And if you've ever used telemedicine, you know, after a while you forget you're talking to a TV.
Yeah.
You really feel like you're there in person, and that person is spending that dedicated time just with you. So, you know, that is also another way that we can battle this. If we can't have the services there locally, you know.
Thank you.
Senator Flynn, I'm really terrified because you can't unscramble the egg, to be really clear. Like this is what it is. So I think that the number one call is we've got to have this comprehensive approach that starts looking at those local dynamics, right? That starts looking at not only the capacity within the hospital, but also the cost. And what I'm really worried about, what we see in so many of these places where you don't have any kind of competition, that suddenly means that you can charge whatever you want for care, right? And ultimately what that means, we have a giant fight that's going on between insurance companies and large, we're not talking about the local hospitals, we're talking about the giant hospital health system corporations, right? That's going on, and unfortunately the person that's caught in the middle of that is patients. What they end up seeing, you know, when you talk about those days where, you know, you used to be able to kind of like look around, or I don't think that many patients shop for care, but you could look around and say, look, you know, like if I have to pay for a deductible, it costs $600 here. Like I always in the testimony, there's an example using St. Clair, you know, very low dollar amounts, right? You know, at a smaller hospital but if you go, you know, over a tunnel through the tunnel and over a bridge in Pittsburgh, right? It's 5 times the cost on the other side. And then you go just a little bit up and it's 7 times the cost up there. So I'm really worried not only that there's not enough access, but that patients are going to not only have less access, but higher costs. And that's another part of this, because with the decrease in access, if the costs follow the trends that we're seeing, then that means that the patients have even less access than what they have on paper.
Social care, capital cost, capitalism, social.
I think that we're talking about there's just lots of market failures here, right? I mean, I think I have to be, you know, Senator Muth pointed out, you know, the question about private equity. I have to balance myself because we don't have the legal fees to take on any private equity corporation, right? But
Write it down on a note card. I'll say it for you, Patrick.
Thank you. But I really do think, you know, I think that we have to look at the patient, what the patient experience is, right? It's not just about the hospitals closing. It's about they're starting to see their co-pays, deductibles go up because the remaining hospitals that are left are charging more and more for the care.
Yeah, but you also have to look into the business models that are nonprofits take for tax purposes.
Absolutely.
About, we'll buy this, we'll write this off, we'll run this one into the ground, then we'll buy
yes.
another one, write that off, and then the next year we can make a profit on this one. And I don't think the public is aware of the profit schemes that are going on hospital to hospital through this nonprofit system. And that's what I think what our job is, to illuminate that. When CHS came in here and said they were gonna, they promised us that they were gonna invest money in their building and facilities, and basically ran it into the ground where there's like water leaking and all kinds of stuff all over the floor while they're trying to give care to patients. You know, it's a fake bill of goods they sold, you know. And that's not right to the taxpayers. That's not right to the state of Pennsylvania to do that, to make that promise and that contract. And then we step up with funds and they don't deliver on their promise.
Can I ask a clarifying question? It sort of tags along with what you're saying, Senator Flynn. So when, Patrick, you're describing the different rates within a hospital system, and I will take the heat for this example because it is my lived example. So whatever, UPMC can sue me. So, well, I mean, I was a patient, so I feel that I should be able to share this patient story. So, back in 2023, I was driving home from a Senate Veterans Affairs hearing in Beaver County, and I thought I was having a stroke. I felt weird. I pulled over at the Turnpike rest stop in Somerset, and I felt like weird. Like, and I didn't feel weird all day. So I called my husband, and then I couldn't talk. I physically could not talk. So he called 911, which is a whole separate hearing about the 911 dispatch system. But God bless that whoever makes that, 67 county thing work. But is that so I had an ambulance bill that doesn't get, because ambulances don't get directly reimbursed. The insurance company sent me a check, which you have to send to the ambulance company, and then I ended up staying overnight. So I had 2 different imaging. I had an MRI and a CT scan. And so actually last week I just got something from our health insurance in the Senate. I think it's Blue Cross, right? Independence, saying like this was covered or it was like paid out to them. I'm like, this is almost over a year later. So I don't understand. I was in the same building. I never left the building. I didn't go to an outside MRI, like, whatever. So my question is, I'm in Somerset County, which is that hospital, if you're not familiar with that location, is in the heart of like the city, right? Like the area, I mean, it's surrounded by people, houses. It's not in a remote area. Everything was telehealth for a specialist. So the neurologist, the stroke doc, all of these things, right? And it was later in the evening, so maybe that was part of it. But even in the morning, there was no neurologist there. It was back to talking to my guy in the little box. And, I guess my question is that hospital, and I got to chatting with the ER doctor who worked at the methadone clinic. He volunteers on Friday morning. So I think it was a Thursday evening, and he was done at midnight. So we were like, talking shop before I got moved upstairs. And so this is a high need area, but there's no specialist. So just because there's a physical hospital and I'm not saying those two people that assisted me via telehealth were helpful. I don't know that that was the best patient experience, I would say. But it is what it is in that moment, right? You're just trying to rule out the worst possible things. And it turns out I just had really, really low potassium, which is like really odd, but I mean like super low, and you can go into like a coma from that. I had no idea why. It was really random. But I ended up having 2 inflamed cranial nerves. So like you're talking to these people, you're not at home, I'm by myself, I'm nowhere near home. Thankfully my dad lives 45 minutes away because I'm from Western PA, so he came and sat with me in the ER with my stepmom. But my point is, what if I was at a different location, do the people that go to Somerset UPMC, are they paying a higher, like, is it more, are they charging more? Is that because it's rural? Is that sort of like an example of what you're saying? Because of that really is unfortunate, especially because the majority of their care for specialists likely is through telehealth. And again, telehealth has its place. It's very helpful. But how do you do a neurocheck?
How do you do a neurocheck when you're on how do you say, can you feel this? That baffles me. Neurocheck, neurosurgeon, you gotta be bedside and not on a telephone.
Or at least at some point, like somebody, yeah. And so I just say that as like, we're talking about the system being drained financially, staff-wise, but it's also like, we don't even have the specialist, and it's like, well, who's gonna pay a neurologist to live next to the hospital? And is that the barrier? Like, so it is hard, but it's like, again, it's that continuum of care is filled with telehealth, which is better than nothing. But in certain situations, like if you were a prolonged cancer patient, like my aunt was, who went to UPMC in Pittsburgh, if she had to do that telehealth, that screen would not exist. Those visits were rough. They were not fun. They were emotional. Like she just would have freaked out. Like, I mean, she was, 47 with small cell lung cancer. She's not a happy patient, rightfully so. But again, like, that might be the only thing some people ever have. So it's like, how do we get the providers, as said, versus like, are these hospitals that claim to be saviors, right? Like, are they really who they say they are?
Senator Muth, I think that going back to my opening remarks, I think you just summarized what has snowballed into a care hell, right? In a very long, but it is that complex, right? That is the snowballing effect that we're kind of talking about right
And
here.
I want to make sure everyone understands, like, the Senate's health insurance should be every human on this planet's health insurance.
Right.
I want to say that our health insurance, to the point where when I had to get follow-up MRIs, I had hospitals calling me. How did they even know? I don't even know. I'm not kidding. Like, because they knew they were going to get the full reimbursement,
right.
Which I was like. Meanwhile, the health insurance company calls you and says they give you you're approved, whatever, and they tell you if you book this with the hospital system, it might not be all covered. You might be but I've never had $1, other than a $5 copay for a prescription and $10 at the PCP or something. But I've never paid $1 for that should be every single person's reality, right? That they should never. It covers hearing aids, for God's sakes.
And we see, we're at a time where FAN has been doing the research for a long time. But your experience is the opposite of the vast majority of your constituents, right? The fact is that more people are putting off care than ever before. They're delaying care, they're skipping their medications, they're not following, up with diagnostic tests and procedures because they simply can't afford it. And we don't, the evidence is really clear across the board. I think this is all about, how do we prevent healthcare deserts or those deserts even just for individual people? And the answer is quite clear. Consolidation promises a lot of high quality, access to resources, better, insert business jargon here, right? And in reality, quality is pretty much maintained, if not dips, but costs go through the roof, right? And that's, I think, when we get to that moment, your bedside experience wasn't, the one that you wanted,
I mean, I'll
right?
say I had two great
Right.
nurses who, like, literally
Absolutely.
one who which got me to be able to stay overnight for additional imaging. And
But so
but
there's-
again, it's
yeah.
it's hard.
There's a great chance that what was ultimately paid for that was incredibly high, and the experience may not have been exactly what you wanted in that moment. That sounds very stressful. So I think that's again, to avoid this snowballing, right? The only thing that we have to work on workforce, we have to work on reimbursement, but then we need those accountability mechanisms in place. We need them strong, we need the clear data, and we need, that transparency with teeth that's going to be able to say, okay, this is the only way. We can't unscramble the egg, it's what we got, but how are we going to make this the best for patients? And I think that ultimately, if we can put those solutions together, we're in the best place.
And I guess my final thought is, and chime in, because might be controversial for those who are tight with anybody in the Insurance Federation, but the other piece we touched on reimbursement rates and for Medicare and Medicaid, which desperately need increase. That's a known thing. The other piece of the transparency pie is like health insurers, what everybody's paying, what they cover, and then having some of these insurance companies not, like for example, there's one of them stopped providing coverage at CHOP. I represent Southeast Pennsylvania, so all those people that had that provider for insurance, it's either like go find a new doctor instead of your person at CHOP that your kid might have had, for however many years, and also the coverage piece from family to family. Representative Friel and I had some pretty intense Zoom meetings with one insurance provider about a child that desperately needed a cerebral palsy experimental treatment that other kids at CHOP had gotten approval for, and this one family for whatever. So we were very curious as to how these things are denied versus covered, and so like the insurance companies really do fuel this, because why, remember UPMC and blocking certain, and like they wouldn't take certain coverage, like that's another huge barrier, and it's a for-profit barrier somewhere, whether UPMC is nonprofit or not, but insurance companies make a lot of money. A lot of people have insurance and never end up needing it, but it's good that you have it. But how do we eliminate that coverage prohibition for X, Y, and Z provider just because you don't, if you're paying for health insurance, in my humble opinion, you should be able to go get health care wherever.
I think you just set the agenda for the next policy committee hearing, because but also let us remember, we're here to talk about hospitals, but a lot of those hospitals are owned by insurance companies. And so I think that we really need to kind of explore deeper, like we're here to kind of talk about healthcare deserts, but some of the people that are kind of involved in this picture are not only controlling the hospitals, but they're controlling the insurance product that ultimately sets the rates that you as a patient pay. And so it literally gets back, the best way of saying this is it gets back to the metaphor of a company store. You set the wages, you set the product, you set the price, and then you're consistently in debt. And ultimately, we're at a point where the House has twice looked at reforming medical debt in Pennsylvania because we're at a place where we are at record levels of medical debt, and we've twice passed on a bipartisan basis medical debt reforms that not only were included in the governor's budget proposal for paying off medical debt, but also reforming the system to make sure that no one ends up there in the first place. And so I just want to highlight to our Senate colleagues that this is really top priority. the House has kind of done its piece, and we really need to mobilize the Senate and put pressure as we kind of come into the budget process to get that done, because that medical debt is a direct result of what you're talking about, this set of integrated delivery networks where you've got an insurance product, a hospital, and the patient that has uncovered lives, and they can't go. Once you're in that system, you can't get out to the other side if you want to. So thank you for, I think I just heard you say you're ready to sponsor a hearing on that.
It's a really important issue because when I was in grad school, it was before the Affordable Care Act, and I had to take out student loans to pay for that health insurance coverage we were required to have as grad assistants. And so it is a huge sum of money, and that was for like the lowest coverage ever. So I still had a lot of out-of-pocket costs on an $8,000 a year stipend, for being a grad assistant. And that's a lot of what happens when you are in these medical professions going through your education, is that you're required to have health insurance, but you don't have a full-time job. Right. And so that's another piece of this. And I've met during COVID with some UPMC workers that had mass amount of medical debt from getting COVID, on site, and they knew it would happen. It's a hospital system, but their health care wasn't paid for, and they work at UPMC. And so it is insane, and it's obscene, really. I mean, it shows that, to Representative Williams' earlier point, when I will never be bought in to the idea that health care is a business, because that's taking care of people should just be a given, and not based on how much you can bank and write off and recoup. And a lot of these entities, yes, are corporate crooks, and it results in a lot of harm. I'll go to closing remarks. You want to go first?
I guess ditto to everybody. Yeah. Thank you both for being here very much. You're both advocates for your patients, for your staff, and we are advocates for our constituents. So I think we're all here for the same reason. But when we talk about the rapidly accelerating healthcare deserts that we face here in the Commonwealth, we have to do something. When I think about sending OBGYN patients who, and sometimes it's not transportation, it's time. Lots of people can get transportation. That's not a problem for a lot of the families, but sometimes they just don't have the time to get to the facility that they need to when they're in the acute crisis that they're in. Certainly you spoke about acute psychiatric crisis in an emergency room. That is the worst place for a patient that's in an acute psychiatric crisis to be held, in a place with so much stimulus. And these specific specialties are what we think here at this table. I know that we all have legislation, or we all support legislation to help, but sometimes that takes time. I don't know if you know that. Sometimes Harrisburg takes time to make things happen. And yes, so we.
Oh, do we ever?
Yes. So I think that this is more of an acute issue that we need to face, and we need to fix, and we need to solve. And I appreciate you being here today with solutions, and I think we're really looking forward to working with you in the future. So thank you very much for being here today.
Senator Flynn?
Yes, it was great having you guys. I always defer to Representative Kosierowski for all my medical advice in the healthcare space, but as we're educated on the issues, it's just such a cumbersome issue, and like as a legislator, you kind of know a little bit about everything, but it's just such an overwhelmingly huge billion-dollar, trillion-dollar state U.S.-wide industry, and in grasping some of the concepts and what goes on and how it's a Wild West in PA as far as reimbursement, and it's just crazy. And it needs to be, we need to have a better grip and regulate this better. So I look forward to working with you guys in the futures and coming up with some solutions. So thank you.
Representative Bizzarro.
Thank you, and thank you for being with us today. And I want to thank you for highlighting some of the important work that the House has done. Present company excluded, it is time that the Senate get their act together and start running some of these bills. We have a lot of motivated senators, Democrat senators, who are willing to do the right thing and put these bills up and actually make the type of tough decisions to make these reforms become reality. But it is amazing what a new, humble majority in the House can do, majority by one member, prioritizing people in this Commonwealth and putting people first. So, Mr. Keenan, Dr. Torres, thank you for sitting in the hot seat for nearly 2 hours. You all been great. Thank you for the information. We've got a a lot to work on, but we thank you.
And I just want to echo our gratitude from the Senate side for, it's always great to work with the House because even though we're in the same building together, as mentioned, there are different circumstances in each chamber. And so the Senate has had a stronghold majority of the party that I'm not affiliated with. And so for over 30 years. So it is very difficult when it was mentioned earlier that these are not partisan issues. It's amongst the electorate, the voters, the public, that these aren't partisan. Everyone agrees that there's no disagreements that you should be able to have access to health care if you're sick and need assistance. That's not something that's debated amongst our neighbors. It certainly is in Harrisburg, and that is sadly the pay-to-play system in politics in Pennsylvania, and it kills people, literally. And so as someone who sits in the minority in the Senate with no power to do anything, it's very helpful to have things in the House to point to and bills that have been sent over to us to say, hey, why aren't these bills moving? They would help constituents living in all 67 counties and all 50 Senate districts, regardless if they are represented by a Republican or a Democrat. And so I just want to say thank you to both of you for letting us talk through some of this, getting your perspective, and for being persistent and staying in this fight, because it is a long haul and it can be quite daunting. And I know I've made friends with a lot of nurses at the veterans home that's in my district that's run by the state, and a lot of them have left taking care of these veterans because of burnout, right? If there's not enough staff, it's hard to go to every shift and be down 2 people and work in the memory unit and have behaviors to deal with and things like that. So it's not that healthcare providers, we have a lot that have left the field because of those things, and we not only need to recruit more but retain those that we have. And I think you know, you go into this line of work as a healthcare professional because you care about people and you want to help, and when the system is preventing you from doing that in whatever capacity it is, we are where we are because of that. And I think as mentioned, there's a lot of solutions on the table, all of which would do some level of good, and certainly the reimbursement rates is at the state level somewhere to start. Yeah. But it's a necessary lift, even though it's a big one, and it's you know, yeah, it's been 10 years. We can, yeah. So I look forward to working with all of you moving forward, and certainly we'll be fighting for these things in the Senate. And thank you again for joining us today. And this is all posted online, the recording, and for anyone that wants to watch it. And I hope you have a great rest of your day. Thank you. Thank you.